Make sure you know why you want to be tested. Second of all is make sure that the test is a reliable test, and I think here at Overlake we're using an Abbott test that's a send-out test. The UW also has that same brand of test, and that has good reliability. The cost, I think, varies depending on where you have the test done. I think it's between $50 and $120 roughly. One is an early phase, what's called IgM antibody. That's the initial antibody that we produce when we get an infection. That usually peaks out at 4 or 5 days, or is measurable in 4 or 5 days. The other is what is called IgG, and that tends to peak later and last longer. So most tests that you hear about, antibody testing, is for the IgG test. It, depending on the test and who makes the test, the sensitivity, the likelihood of actually picking up the right antibody in the test is somewhere between 80 and 99%, depending on whose data you look at. If you are wondering, have I been infected, and it's been more than 10 days, 2 weeks roughly, you may be able to detect that. If you are wondering, and if that test is positive, the chances are that you have been infected at some point in the past. What you won't know is how much immunity you will have and how long that immunity will last. Because as we know, the virus can mutate, and there may be a different strain actually on the East Coast than what we've seen on the West Coast. So you don't necessarily want to have a false sense of security if your test is positive, that now you don't have to worry about COVID.
My suspicion is that the same social distancing and quarantining that we're doing for COVID-19 reduces the exposure to influenza and other viruses. So merely by having patients and other people in community not interacting with one another, the virus can't spread person to person. So that's why the cases are down.
The answer is no, it is not pretty much like the flu. And the reason is it has a much higher mortality rate than influenza. So throughout this influenza year, this year's influenza epidemic, there were probably between 40 and 50 million cases of influenza. The mortality, there were about 50 to 60,000 deaths in that cohort. COVID, on the other hand, we've had a little over 1 million cases in this country and 60,000 deaths from that much smaller number of infected patients. So the mortality rate, the lethality of this virus is much higher than influenza. And in addition, we know that whereas with influenza, children often are symptomatic, with COVID, often they may be asymptomatic. So they can be a silent carrier and therefore a vector to others of this virus. And even in adults, there may be a period of latent transmissibility during which we may be asymptomatic yet still be able to transmit the virus because we're carrying it before we develop the symptoms. So it's a much sneakier virus and a higher mortality rate associated with it.
At this point, the suspicion is that there's something about the person's immune response that leads to a more robust response compared to others. And that's the going theory right now. We do not have solid evidence of that fact. We do see this in other infections as well. It's just more prominent with this particular viral outbreak.
So Remdesivir is an antiviral medication. It's given intravenously. It is effective, has been shown to be effective in other viral infections, and so far does show promise in limited studies of reducing the severity of COVID infection. We have, in fact, administered this many times here at Overlake and have had, we feel, some success, pardon me, some success in patients who are severely ill in the critical care unit, showing some improvement after administration. It does have some side effects and some limitations if the patient has kidney failure. For example, we can't give them the drug, but it does so far seem to be a promising tool for fighting this virus.